Let's learn what is acute pancreatitis and how to manage it in emergency. Okay, first of all, what is pancreatitis and how to diagnose it? For this, there is a criteria of which two out of three criteria should be met. One, first of all, is pain. Okay, epigastric pain, which is radiating epigastric pain, which is radiating to back, and second is lab value mileage or lipase more than 3 times equal to the upper limit. Okay, and third is the imaging finding from CT or ultrasound, which is consistent with pancreatitis. Okay, from these three criteria, if two out of three criteria is met, then we say that's acute pancreatitis. Okay, now how to manage it? For management, okay, I'll straight jump to the management portion. First of all, we have to give fluid. Okay, fluid resuscitation should be done, and for this there are different types of strategy we can use, but we use aggressive moderately aggressive goal directed resuscitation. Okay, goal directed resuscitation, which means this we can give a bolus of about 10 ml per kg of the isotonic this crystalloid. Okay, crystalloid, and for this ringer lated is preferred because it decreases CRP, and it also decreases the sepsis, okay, due to pancreatitis. And we can give a 10 ml per kg of bolus and 1.5 to 3 ml per kg per hour of fluid after that. Okay, and we have to look for any sign of fluid overload, like any pulmonary edema or abdominal compartment syndrome. Okay, and if we think it's the patient is landing on this, then we have to decrease. Okay, and for pain management, okay, next thing is pain management. First of all, that was our fluid. Okay, and fluid we use this waterfall. There is something called waterfall study. We studied moderate aggressive fluid to the aggressive fluid management, in which we use 10 ml per kg of pollution. After that, 1.5 to 3 ml per kg per hour of continuous fluid. And for pain management, we do is multimodal approach. Okay, previously we used we we had used pain ladder, but at this time these days we use multimodal approach, which means we give concurrently multiple pain medication, like uh, IV paracetamol, NSAID like Kitrol, and tramadol or undame, tramadol slash and undame. Okay, we give concurrently these three, and if severe or not relieved, we can give pethidine 50 mg 6 hourly, or morphine 5 mg every 4 hours. Okay, along with that we can give undame as well. So we give concurrently 2 to 3 this pain medication to decrease the pain, and this reduces this. If we give concurrently these three, then we can decrease the higher these opioids like morphine, which causes more sedation and might land into ileus as well. Okay, and next thing is nutrition. Okay, nutrition. For nutrition, we for mild cases we give we do not keep the patient in NPO, and for moderate to severe cases we wait till the patient is able to eat orally. Okay, there is no nausea and no pain, then we started giving the oral feeding. Okay, and what about antibiotics? Okay, antibiotics, in case of antibiotic, we do not use antibiotic prophylactically, and we use antibiotic only when we have suspected or confirmed infected necrosis. Okay, and this is case of gas in necrosis. We tell that it's infected. Okay, and we use in if there is any extra pancreatic infections like cholangitis, any pneumonia or UTI, something like that. If there's any extra pancreatic infection, we use antibiotic. If we suspect it's infected necrosis, okay, and then we give antibiotic, or there is clinical sepsis, okay, which is not explained, otherwise. Then we give antibiotic. Other than that, these three indications, we do not give antibiotic. And if we use antibiotics for pancreatitis, we use the antibiotic which will penetrate our pancreas. Okay, and this can be carbapenems, okay, imipenem or meropenems only. And okay, after that, when do you do CT or MRI? We often wait the CT and MRI till 72 hours, because at that time we can also monitor for complications. Okay, and if there's only urgent indication is there, we wait till 72 hours. Okay, and along with that, we also go for etiological our diagnosis as well. Thank you.